So I'm going to start with something you should never do in a talk, ask you to take out your mobile phone and see that thing there, the internet connection, ztings.com/Dr. Matt. So this is for the people who are in a health service or working in a hospital. I do my own market research on you. So I'm the chair of the advisory board for Choosing Wisely Australia, but also the clinical lead at Charles Gairdner. So in terms of, I suppose, places that are thinking of starting, we took this approach at Charles Gairdner to try and think about what items might have impact for us. We came up with a sort of an evaluation framework. So is the item that we're going to pick a high volume or a low volume item? What's the unit cost? What's the patient safety benefit? So is there a risk to the patient if they get this test or not really a risk? Can we measure it? So unfortunately, our hospital is still largely paper-based, and so a lot of these things are not easy to measure. And do we have the ability to change behaviour? So I left that one blank because that's always the uncertain part when you embark on these projects. You can use a Choosing Wisely list, and there's lots of countries to choose from, or you can pick an Australian list, obviously. And do you want to start with pilot data from your own sort of unit? So I work in an intensive care department. Or do you want to do one item across the hospital or across your whole health service? How does it fit in with the rest of your hospital? Are you being accredited with national standards? Is there something that you need to get up to speed with in the upcoming weeks or months? And can you get some numbers if you're going to pick something? Because there is a link between behaviour change and what you can measure. So we have two projects I'm going to talk about. One is Optin, which is a pathology-based testing thing as well. We started with a pilot project. So in the ICU, we ran this project with an enthusiastic trainee, and there was a Choosing Wisely item from the US, which was don't order blood tests on a routine basis rather than in response to clinical indication. And we looked at coags as well. And so the things that you can see there is total coags per bed day. Looked like we did a coags on everybody. And then we sort of audited that and looked at what were unnecessary, so they didn't need it at all. They had no bleeding problem and yet we repeated it every day. Or inappropriate. Could we have just done a targeted test for the anticoagulation that they were on? And you can see we pretty much dropped use by 63% by changing the order sets that we used. So we had designated order sets that were clicked on the computer for ordering and an education rollout for the staff. To be honest, I think the education was more about telling them that the order sets had changed rather than the behaviour change, because the behaviour change came from changing the order sets. And that was published last year. So from that, we thought, what can we do hospital-wide? And so there'd been other pilot projects in haematology reducing blood usage, in the emergency department on blood gases. And we looked at the pathology billing data. So that was the data that we could get, was what we were being charged for. And then we looked at that in different pilot wards that we thought were engaged and interested. And I'm going to actually pick one that is the probably the outlier of all of those five there that you think, neurosurgery, but they were actually our most successful unit. And they picked for them group and screens, coags and frozen sections. What they did is they changed their default order sets for ordering, changed the clinical pathways at the ward level and educated the staff. And they looked at pathology billing data, and they looked and found that they could reduce coagulation profiles by 30%, and frozen section, which is a way of looking at pathology sort of in real time when an operation is happening, by 50%, which is pretty impressive from the neurosurgeons. Our second project we've called Byebye PPI, and this is sort of an adaptation of a Choosing Wisely Australia item that is not necessarily hospital-wide, but essentially people don't need PPIs for a long time. For us, the reasons to tackle this was that it's high volume. There's a low incidence of harm, but those who do develop harm have a significant results from that. So linkage with pneumonia, dementia, and nephritis. And for us, this was a trial at looking at deprescribing, a bigger topic within this sort of space. So we looked at the high use areas. So again, we'd done a pilot project in the ICU, and we saw that we were starting a lot of people on PPIs and then forgetting to stop them when they left. So we looked at the, created an algorithm for the wards, and we rolled that algorithm out to all the pilot wards that we did. We realised that education for this had to be multidisciplinary. So the pharmacists were the key to this, being involved because they do the medication reconciliation and discharge. The people who are writing up the medicines are often the junior medical staff, but often the nurses would also be giving an extra sort of guideline to the junior staff, oh, you've forgotten to write up their PPI or something like that. The thing that we found was probably the most important for this is we have a discharge summary that is electronic. And if you ordered on that discharge summary a PPI as a medication, we made it a mandatory field that you had to write instructions to your GP. And so that went, indication was improved on our discharge, but also the comments to the GPs went up from 0%, so nobody was writing any discharge information, to 20%. So some people can still override that by just leaving a dash or something, but information improved dramatically in de-prescribing PPIs. Interestingly, the attempts to stop it in hospital remained low, and I think that's partly because a lot of patients move through the hospital very quickly and people don't always feel the ownership to stop them. In the ICU, we actually dropped things by about 35%, but we had much more ownership over those patients and we knew the indications they were being started on. So I think for us, these are our lessons in a sort of top 5. Successful pilot projects really tell you what the sort of the environment is in your hospital and gives you an idea of who can be a clinical champion. Deciding what to focus on for your hospital is really important because every hospital might have a different area that they can look at. We became a Choosing Wisely Champion Hospital, which I think really helps with your executive to say, look, this is important. You have some status amongst your peers. Thinking about what makes it sustainable. So you don't always have that keen trainee who's going to be pushing it the next year. What can you work into your workflow that makes this happen when the residents or the medical staff rotate? And then the last thing is don't forget your business case because you need someone to be able to be on the floor going around doing a lot of this work. We have managed to get 0.2 of a project officer, which in our environment is pretty good. And so that has been, enormous amount of benefit to us. So thanks to Megan, who's our project officer, Damien, Chantel, and others. Any questions, please, there? And maybe later you can tell me what you're working on.